Thank you everyone for joining us this afternoon. This session will focus on efforts around hepatitis C prevention here in Georgia, discussing the landscape of viral hepatitis statewide, collaborative efforts, linkage to care, and treatment barriers. Today's session will consist of 3 panelists. I will be our first panelist this afternoon. My name is Amy Gandhi. I received my Master of Public Health in 2002 with a concentration in community-based health. I currently serve as the lead for the viral hepatitis epidemiology team at the Georgia Department of Public Health, overseeing viral hepatitis surveillance and prevention efforts. Prior to this role, I served as the viral hepatitis prevention coordinator for the Georgia Department of Public Health for 8 years. In this role, I provided training and technical assistance to public health and private providers, as well as community stakeholders, as well as monitored viral hepatitis vaccination and testing activities throughout the state of Georgia. My prior experience also includes HIV and STD surveillance, prevention, and program planning. Our second panelist will be Ms. Patrice Early. Patrice graduated in 2016 with her Master of Social Work degree, inspired by her family history with substance abuse and her experience as a Black woman raised in an underserved community in Atlanta. Patrice moved on to work in positions where she could support and empower people that use drugs and communities of color. Patrice acknowledges how support and resources provided by others propelled her to move beyond even her own expectations for herself, and this fuels her passion to do the work that she does every day. Patrice currently serves as the manager of the Linkage to Care department at Atlanta Harm Reduction Coalition. Our final panelist will be Dr. Leslie Miller. Dr. Miller is an associate professor in Emory University's Division of General Medicine and Geriatrics. Her clinical expertise, research, and teaching center around primary care-based hepatitis C screening and treatment in underserved populations. Dr. Miller is the medical director of the Grady Liver Clinic, a primary care-based hepatitis C clinic that provides care for underserved patients with hepatitis C at Grady Memorial Hospital in Atlanta, Georgia. Dr. Miller leads nationally recognized HCV screening and linkage to care programs and lectures broadly on hepatitis C screening, treatment, and alternate models of care. She has been recognized as a hepatitis elimination champion by the Task Force for Global Health. So again, thank you all for joining us this afternoon. I will begin with a presentation around viral hepatitis surveillance and collaborations here in Georgia. Okay, as I mentioned, although the focus of the panel really is to focus on hepatitis C, I'll be sharing a little bit about the landscape of what viral hepatitis looks like here in Georgia around hepatitis A, B, and C. I'll also share a little bit of information on some of the partnerships that we've developed here in Georgia with the Department of Public Health and collaborative partners to address viral hepatitis and their role in hepatitis elimination. So as I mentioned, I'll start with talking about surveillance and what the landscape of viral hepatitis looks like here in Georgia. First, to start off with hepatitis A, as many other states, Georgia has also been experiencing hepatitis A outbreaks since June of 2018. As of August 8th, we've identified 1,217 hepatitis A infections among individuals age ranging from age 3 to 86, with a median age of 45 years. 64% of these cases have been hospitalized, and we've identified 8 deaths with this outbreak. We also have a high rate of co-infections. 2% of our cases that we've identified are co-infected with hepatitis B. 14% have been co-infected with hepatitis C. If you look at the patients that have been co-infected with hepatitis C, 84% of those are in specific areas of the state, specifically in North Georgia, along the Augusta area, along the South Carolina and Eastern Tennessee borders. We've also seen 8% of our cases having been co-infected with HIV. Again, majority of those cases have been in the metro Atlanta area, and primarily among gay and bisexual men. This just shows a bit of a timeline of our outbreak since its start. As I mentioned, the outbreak started in June of 2018. At this time, we had identified a small cluster of infections in central Georgia that were primarily among HIV positive gay and bisexual men. In the fall of 2018, we began seeing increases in North Georgia, primarily in those counties that were bordering Eastern Tennessee. And these cases were primarily driven by illicit drug use, both injection and non-injection drug use. By early 2019, we began seeing increases in the Augusta area, primarily bordering South Carolina. Again, these were also driven by illicit drug use. Around the same time, we also began seeing cases in Metro Atlanta, primarily Fulton County. However, this time, these cases were primarily among gay and bisexual men. In the fall of 2019, we began seeing those cases spread to other counties around Metro Atlanta. However, with outreach and vaccination efforts that we had put in place, we began seeing decreases in all of those areas. However, this past spring, we began seeing increases in other areas of North Georgia, and again in Central Georgia. However, this time in Central Georgia, the cases were being driven by illicit drug use versus gay and bisexual men, which is what we saw at the beginning of this outbreak. Again, although we did see outbreaks among MSM populations, those areas are now shifting, and we're seeing more of those cases being driven by illicit drug use. So here in the Metro Atlanta area, most of our cases now have a drug use risk factor associated with them. So statewide, our primary risk factor is illicit drug use for this outbreak. 54% of our cases have reported illicit drug use. And if you break that down even further, 51% of those cases used injection drugs, 54% used non-injection drugs, 27% reported both injection and non-injection drug use. And for 38% of those cases, we identified that there was illicit drug use. We just weren't able to determine whether or not it was injection or non-injection. Shifting to hepatitis B, we continue to see acute hep B infections in adults. Typically, we see around 100 to 120 cases per year of new acute hepatitis B infections. Although we did see a sharp increase in those cases in 2018 when we had nearly 180 cases that year identified. Georgia also has a fairly high prevalence of chronic hepatitis B infection. This is primarily because Georgia has a very large foreign-born population as well as a large refugee population in Georgia as well. As far as the demographics of what we're seeing with our acute hepatitis B infections, again, these are the new infections that we're identifying. Our infections are primarily among males, primarily among whites. And you can also see that the primary age group where we've identified acute infections are those adults between ages of 30 and 50 years of age. One thing about our risk factor information with our surveillance data, it is limited. However, I did want to at least point out the increases that we've seen in the past 5 years in acute hepatitis B infections among those that reported illicit drug use within 6 months prior to their diagnosis. We also saw an increase in those that reported as ever using illicit drugs in their lifetime. Okay, so now shifting a little bit towards hepatitis C infections here in Georgia. As many other states have seen, we've seen a steady increase in acute, again, brand new hepatitis C infections between 2013 and 2017. But we did see a decrease in acute infections over the past 2 years. As you may know, acute new Hep C infections are very difficult to identify, as many people don't have infections, or don't have symptoms when they're first infected. So we know that the number of cases that we've identified, that the true burden of acute hepatitis C infections is likely much higher than what we've identified. Here in Georgia, again, as many other states, we also have limited capacity for surveillance around viral hepatitis in general. And we tend to focus on the younger age groups. So we may be seeing a decrease because some of those acute infections may be shifting to older age groups, or it may be a result of decreased testing. It's hard to know what caused that decrease these past 2 years. Georgia also has a high prevalence of chronic Hep C infections. However, you can see in this graph that nearly half of our chronic cases are classified as being probable. What this means is that we don't have an HCV RNA result for those patients. Georgia, as of right now, does not currently require negative lab reporting. So some of these cases may have been tested RNA negative, but we would not have gotten those results. However, we do know from our surveillance efforts that many of our cases, they never have an RNA done. So that kind of shows us a need to continue training providers on the testing recommendations and reflex to RNA testing. As far as our demographics, our acute hepatitis C infections have been primarily among males, but we've also seen an increase among females over the past few years. 78% of our acute infections have been among whites. This graph shows us both acute and chronic infections combined. And as you can see, as expected, majority of our cases are in the 50 to 70-year age group. However, you can also see a steady increase in cases, not only in those cases between the ages of 20 and 30 years old, as well as, but if you look at the age group of those between 30 and 40 years of age, you can also see a sharp increase in that age group as well. As I mentioned with hepatitis B, risk factors for hepatitis C are also very limited due to our capacity to do surveillance in the state of Georgia. But for our acute infections that we've identified over the past 5 years, 27% of them reported injection drug use within 6 months prior to their diagnosis, and 22% reported non-injection drug use within 6 months prior to their diagnosis. Okay, so now that you have a bit of an idea of what viral hepatitis looks like here in Georgia, I wanted to shift now to talk a little bit more about how health departments can and are playing a role in efforts around hepatitis elimination and some of the collaborations that we've put in place at the Georgia Department of Public Health to address viral hepatitis. So what roles do health departments play? So health departments, especially viral hepatitis programs, are key, I believe, in bringing together internal and external partners. Local and state health departments are able to educate communities, offer free or low-cost testing, provide adult vaccinations, link individuals to treatment, mental health and substance abuse services, coordinate training for providers in testing, diagnosis, and treatment. We're also able to leverage funding to build capacity, both for health department partners as well as our community stakeholders. And we're also able to build partnerships to expand testing, adult vaccinations, and linkage to care efforts. So one of the partnerships that I do want to highlight that we've established here in Georgia is with the Atlanta Harm Reduction Coalition. Georgia, I want to mention too, is fortunate that we have been allotted some amount of funding from our state legislature specifically for hepatitis C testing. It's a small budget, but we've been able to leverage it to build partnerships that target both vulnerable and at-risk populations. And one of these partnerships has been with the Atlanta Harm Reduction Coalition. Our partnership dates back to 2016 when we began supporting Atlanta Harm Reduction's efforts around Hep C testing. At that time, we were supporting rapid point-of-care testing and reflex HCV RNA testing through our state lab. And over the years, we've seen between a 15 to 20% positivity rate through Atlanta Harm Reduction's efforts. Currently, we continue to support HCV RNA testing for Atlanta Harm Reduction, and we'll also now be supporting hepatitis B testing among their Hep C positive clients. And then more recently, sort of as a result of our hepatitis